Good afternoon, everyone, and welcome to the School of Public Health noon meeting. The focus of this particular noon meeting is on occupational medicine. For those of you who don't know me, I'm Professor Mohammed Jibai, and I'm the head of occupational medicine here in the School of Public Health at the University of Cape Town. We are very fortunate to have in our midst Elize Lourens, who is a specialist in chemical stressors in the Directorate of Occupational Health and Hygiene at the National Department of Employment and Labour. And we have chosen for our particular topic for today is the recently released national regulations on occupational exposure to lead. As some of you may know, that the last regulation is over 20 years old. I think Elize can correct me there. And so it is a very welcome development in relation to bringing our standards more in line with what is happening internationally. Given that very recently the hazardous chemical agent regulations were also updated. So we're going to have Elize, who has very graciously agreed to give us a presentation on the elements that pertain to occupational health and hygiene and its relevance for our current practice. Thereafter, we will open the floor for questions and comments, and then we hope to finish before 1 p.m. So, can I ask all of you to please mute your mics, keep your video on what's the word, off, switch your videos off. And so that we give the floor to Elize to do her presentation. Thank you very much. Over to you, Elize.
Thank you very much, Prof. And good afternoon, colleagues. Thank you for that introduction. And as stated earlier, I'm going to switch off my camera. It just saves a little bit on the bandwidth, and hopefully we won't have any connection interruptions because of that. So, but yeah, hopefully everybody has seen what I look like. So I would just like to add to that introduction that Prof gave, just to state that my background is not in occupational medicine. I am a registered occupational hygienist, and that is my background. That being said, the TC7 who developed these draft regulations had the very fortunate use and inputs from 3 very competent occupational medical practitioners, and actually 2 of them are occupational medicine specialists. So we were very happy to have them, and the inputs they made, you will see, are of great value in the regulations. And I'm also using that as a little bit of a disclaimer as well, to deal with questions. So if there is questions from this audience specifically, which I'm not able to maybe deal with this afternoon, I will definitely take it back to those colleagues and get back to you with a proper answer. Now, that also being said, the purpose of this presentation, and when we present on draft regulations that are out for public comment, the intent is not to, when we present it, to actually enter into a debate around the requirements that are in the draft. This is really more like an invitation for stakeholders and affected parties to have a look at the draft regulation and be invited to make comments, to make corrections, to make proposals around this draft. So the idea is then, after today's presentation, that you are more than welcome, and we really appreciate then your inputs in a written format so that the technical committee can consider those. So I think that is enough of a little bit of a background around this. I'm going to move on, excuse me, to my next slide. Can just get it moving again. There we go. So the contents that I have up here of the regulations and of my presentation this afternoon is very much the contents of the regulations. And my intent is not to take you through every heading, as if we can call them that, of the regulation, but it's just to indicate you what is actually entailed in these regulations. I'm going to skip a lot of those sections and just focus mainly on the ones that have an impact on occupational medicine and the health side. But as we all know, is that the medical screening and surveillance gets triggered by certain other aspects in the regulations, and then also the outcomes of the medical screening and surveillance results in other actions. So I'm going to try and very much focus around those areas specifically. Now, moving on to the first section of the regulation is always in all our regulations is the definitions. Now, there are 26 definitions in the lead regulation or the proposed draft lead regulation. There are a few new ones. So I'm just going to look at a few new ones and then specifically look at those ones that have an impact on health, or as we said, on the medical screening and surveillance. So the first one is action level, which means blood lead concentrations that exceed the levels provided for in Table 1 of Annexure B. So we will deal with the annexures at the end of the presentation, but it just gives you an indication as to what is blood lead levels or action levels that must be considered when taking these blood samples from employees. Next one I want to look at is exposed. This is a common commonly used term, and hopefully we can just make sure and standardize the understanding around that term. Means contact through any route of entry whilst in the workplace to lead, qualified as amount of lead available at an exchange boundaries of the worker and available for absorption, and includes potential, accidental, or possible exposure. So it's important to, when we talk about exposure, not only look at what we know to be exposed, but also potential exposure. Intake includes inhalation, ingestion, or any other means of absorption. As we know, this is pretty important, especially when it comes to lead and some of the other hazardous chemicals as well, specifically the absorption through the skin that needs to be considered in this environment as well. If we look at the last definition there on the slide, lead paint, what I need for you to understand about this very technical definition is that it's also a definition that we share with the Department of Health. You would maybe know that the Department of Health has recently published the lead in paint regulations that regulates that environment where there's a manufacture or application of leaded paint. So this very technical definition of what lead paint is shared with that department, and I think it's technical, but it gets to the point. It makes it clear that everybody has 100% understanding of what lead paint or unleaded paint should be. Sorry, I'm just, every time it's a different button that I need to use to move on the slides. Now, the next definition up there, it's a very comprehensive definition, and it's new, and it's of utmost importance to this regulation. Everything actually revolves around this regulation of what lead work is, and you will see how it is used in the regulation as we move through this presentation. So lead work means work that exposes a person to lead, dust, or lead fumes arising from the manufacture or handling of dry lead compound. Work in connection with the manufacture, assembly, handling, or repair of or part of batteries and radiators containing lead that involves the manipulation of dry lead compounds or passing or casting of lead. Dismantling batteries containing lead for recycling, melting, casting, spraying lead, metal, or alloys, recovering lead from ores, oxides, or other compounds by thermal reduction processes, mechanical absorption of metal plant machinery or product containing lead or lead alloys, or the abrasion of any surfaces painted with lead containing paint, electric arcing, oxalate arcing, plasma arc, or flame that is applied to the surface of metal coated with lead or paint containing lead, confirmatory laboratory tests for lead compounds and lead alloys, spray painting with lead containing paint, manufacture test or use of detonates or other explosive ammunition or other explosives containing lead and lead alloy foundry processes, work where lead is produced, processed, used, handled, stored in a form in which it can be inhaled, ingested, or absorbed. So the intent is really for this definition to be exhaustive. So if there's anything that somebody noticed that might be missing, we would appreciate if you can bring that to our attention. We would love to include it in the definition. Moving on to medical certificate of fitness means a written statement issued by an occupational health practitioner in which an employee's medical fitness to perform a function is expressed. Medical screening, this is a new term used in the regulations, means a systematic application of tests or inquiries to identify employees at risk of a specific disorder caused by exposure in the workplace, identifying potential health effects before the employee exhibits symptoms. And then monitoring is a term that is used for both air monitoring or traditionally occupational hygiene, and then medical surveillance or biological monitoring means the planned carrying out and recording of the results of a measurement program. Return to work means blood or urinary lead concentrations as provided in Annex B, at which employees may resume late work. This is just an update and a little bit of a different format to what we have in the current or the old lead regulations, but there is still the use of, removing temporary employees from lead exposure for a specific period. Now, the next definition for a SEC or a similar exposure group, that has a major impact on the approach that the occupational hygienist will take in future, and it impacts on the sampling strategy that they will employ. It means one or more employees having the same general exposure profile because of similarities and frequency of tasks performed, the materials and processes with which they work, the controls in place, as well as similarity in the way they perform the task. So this is for the hygienist, this is of utmost importance. So if they can correctly and accurately identify a SEC and do the monitoring, scientific or statistically viable monitoring for that SEC, we feel that the hygiene program will be very strongly based. Significant exposure to lead means employees who are or may be exposed to airborne concentrations exceeding 50% of the occupational exposure limit, and where there is substantial risk of exposure through other exposure routes. This is also a new approach that we are expecting employers to take action before they actually reach the OEL. Moving on to the next one, suspension level means blood and urinary lead concentrations as provided for in Annex B, at which employees are temporarily removed from lead work to reduce exposure. As I said, the practice is still the same as we have under the current regulations. There's just a little bit of a shift in the information provided in the annexes. Then the last one that I'd like to look at is vulnerable employees. Those of you who are dealing with our regulations a lot might have noticed it coming out in many of our regulations. For instance, the physical agents regulations that were recently or most recently published for public comment, as well as the noise-induced hearing loss. We all used that definition to define vulnerable employees, and the expectation is that the employer should make specific consideration of the exposure. Moving on to the next section of the regulation, scope, as always, and these regulations must apply to every employer, self-employed person at a workplace where lead work takes place, and lead can be inhaled, ingested, or absorbed by any person at that workplace. So here you see this very much leans on that comprehensive definition of lead work. So as I say, it's very important for us to have that definition as comprehensive and complete as possible to make sure that we don't have any workplaces that fall through the gaps because of anything that was left out. Then in line with the regulations for hazardous chemical agents, there's now also a requirement for lead and lead compounds to be classified according to the GHS. The difference here is that we have a compulsory classification provided for already in Annex A in the regulation. So the expectation would not be for a manufacturer or importer to go do their own classification of lead. They will just adopt the compulsory classification that is in Annex A and develop the safety data sheets as well as the labeling around that classification already provided. Identification of lead and lead at work. An employer must ensure the identification by a competent person of all lead work, all lead and lead containing products. These must be entered into an inventory, and the inventory must include the list of the lead products handled, used or stored, all lead work processes, the current SDS for each, the work area where the lead is used and where contact may occur. The inventory then must also be readily accessible. The risk assessment must be conducted immediately and thereafter every 24 months, not exceeding 24 months, and must take the following into account. The presence of any organic or inorganic lead, where the lead may be, the extent to which people may be exposed, the number of employees that are exposed, the nature of work, the duration, intermittency, frequency of exposure, potential routes of intake, recommendations containing in the previous risk assessments, and then historical results from exposure. So that includes biological results as well as air monitoring results that may be available. Continuing on the risk assessment, the hazard properties must be considered in the risk assessment, the health effects, the health risk to vulnerable employees, reproductively able, pregnant and lactating women. The OEL of lead must be considered, and activities outside the norm as maintenance or cleaning projects must also be considered during the risk assessment. Then there's also requirements for when the risk assessment must be reviewed. So yeah, the risk assessment is the starting point for everything. So if the risk assessment indicates that monitoring needs to be done, this is one of the things that will trigger both air monitoring as well as medical screening and surveillance. So it's very important that this risk assessment be done by somebody competent and to be as inclusive as possible. Then there's a very extensive regulation, once again, on information, instruction, supervision, and training. You will note a little bit of a name change there. Usually it was just information and training, but we've added some other sort of subcategories to that to make sure that employers understand the importance of their responsibility when it comes to instruction and training. That it's not just enough to provide somebody with training and walk away. You need to make sure, you need to supervise that the training is actually implemented and followed along the way. Information and training, and then as per all our regulations, it just gives you the scope of what the training should include and what people need to be trained upon. And then there's a requirement for refresher training. And also then there's an instruction to the employer to provide written instructions on specific aspects like emergencies when there is spills or leaks. The next regulation is duties for persons who may be exposed. Now, this one didn't really change from the old regulation, and I'm not going to take you through that. It's just for you to note that obviously our legislation normally places a lot of responsibilities on the employer, but please don't forget there's also some duties on the employee that they must follow any legal or lawful instruction to them that they must report for exposure monitoring, medical screening and surveillance, as well as for biological monitoring. So it's also important for this to be included in the training that employees are well aware of their duties when it comes to them possibly being exposed to lead. Now moving on to where I would say the important stuff starts, looking at exposure monitoring. Now it's not really a change. It is common practice, and it's hopefully what we hope. Yeah, hopefully it is a common understanding that both air monitoring and biological monitoring is considered to be exposure monitoring, because the results that you get from air monitoring and from biological monitoring gets used in the same way. It gives you an indication if the employees are overexposed or there is a potential for overexposure, and to trigger the impossible control measures. So you will see in the regulation for exposure monitoring, both air monitoring and biological monitoring are included there, which is a bit of a change from the previous regulation. So based on the risk assessment, so as I said, everything results from that risk assessment. So based on the risk assessment for the SEC, the employer must ensure that exposure monitoring is conducted for air monitoring. You see there's an A and a B. A then deals with air monitoring, B then deals with biological exposure monitoring. So for air monitoring of lead, if the risk assessment indicates potential exposure of the action level for airborne lead. So remember that is the 50% of the OEL, then we would want to trigger air monitoring if there is an exposure up to those levels. It must be conducted at least every 24 months, and it must be conducted by approved inspection authority. So that is also very much as we have it in the current regulations. We're then moving on to B for biological exposure monitoring. If the risk assessment indicates potential exposure is likely to result in blood lead concentrations exceeding the relevant action level for lead. So remember there is a definition now for the action level for lead. And if air monitoring results contemplated in A exceeds 50% of the OEL, then we would want to see biological monitoring being triggered there. If air monitoring alone is unlikely to reflect total uptake through all exposure routes. As I said previously, especially with lead, skin absorption is a consideration, and that will obviously not be picked up during air monitoring. So if there is a likelihood of skin absorption, then it will trigger biological exposure monitoring. If the health risk assessment identify any vulnerable employees, reproductively able, pregnant and lactating women that may be exposed to lead, and when recommended by the occupational medicine practitioner. The results of air monitoring carried out in terms of one, so that is the air monitoring, must be used to determine the need for implementation of controls, validation of respiratory protective selection, and whether to conduct medical screening and medical surveillance. So as you can see, as we said in the beginning, the exposure monitoring is both of these things, and they are related to each other. They trigger each other. Every employer must ensure biological exposure monitoring of lead other than tetraalkyl lead are included in a baseline measurement for blood lead, which shall be repeated during the 3rd and the 6th month after commencement of employment and thereafter at relevant intervals provided for in Annex B. So those of you who work closely with the current lead regulation will know that there is a phase in provided for lowering blood lead concentrations. Now, all those target dates have already passed, but this is a similar approach. So initially, the first baseline measurements, and then just to make sure that you have an accurate view of what the person's baseline is, the 3rd and the 6th month, and then you fall back onto Annexure B, and we will look at Annexure B at the end. Where blood lead concentrations of an employee exposed to lead exceeds suspension levels provided for in Annex B, every employer must ensure that tests are repeated, and if the results of the repeat test continues to exceed the suspension levels, then the employee must be temporarily suspended from lead work until the blood lead levels are equal to or less than the relevant return to work levels. So all these levels, the suspension levels as well as the return to work levels, are provided for in Annex B. And as there is the use of the term lead work once again. So the idea is that if there is elevated levels, employees get removed from lead work. So it's important to understand where there is, if we can call it, non-lead work taking place, so that we can place those relevant employees in those environments for the interim until their levels normalize and they can be returned to work. Where blood lead concentrations of an employee exposed to lead is equal to or exceeds the relevant action levels, the review and effectiveness of control measures must be undertaken. Investigate the reasons for this exceedance, consider where there are any observable patterns in the employee's biological exposure levels and how these may be related to work practices. So this is the idea around this is that you will have sort of individual profile for each employee exposed to lead work, and that you'll have an understanding of what is their sort of normal, and to be able to react to whatever is outside of that normal. And then the idea is then based on that, then an action plan will be developed. Then we're moving on to total urinary lead levels that needs to be tested at the commencement of employment or thereafter at intervals provided for in Annexure B once again, where significant exposure risk. Sorry, I just have some funny things popping up on my screen, hopefully. Okay. Where significant exposure is identified in the risk assessment of or exposure monitoring, the employer must obtain the opinion of an occupational medicine practitioner to determine whether medical screening is necessary, and informing the opinion, the occupational medicine practitioner must consider if the risk assessment indicates significant exposure risk, including consideration for all exposure or routes of intake. If the results of exposure monitoring identify exposure exceeding the action level or exposure of vulnerable employees. An employer must establish, implement and maintain a documented system of medical surveillance, which is overseen by an occupational medical practitioner. So what's important here is to note that it needs to be a documented system and it's overseen by the medical practitioner. Where the need for medical surveillance has been determined, the medical screening must include an evaluation of the employee's medical, occupational, and exposure history. You will see there's a lot of expansion on this from the old regulation. And the medical screening must include appropriate clinical examination, medical tests to identify signs and symptoms associated with the ill health effects of lead exposure and lead poisoning. The intervals at which medical screening must be repeated must all be included in this documented system. The employer must ensure that this medical screening is carried out by occupational health practitioner immediately before or within 14 days of a person's commencement of employment, where they will be exposed to lead work, periodically as recommended by the occupational medicine practitioner in this documented system, but not exceeding 12 months. The occupational medicine practitioner must notify the employer in writing if, if employee has a medical condition which prevents the wearing of personal protective equipment, where the employee's job requires the wearing of respiratory protective equipment or any other personal protective equipment, or is likely to be aggravated by exposure at that workplace. So this is something that was expected in the past but wasn't really captured in the regulations, is for the medical practitioner to consider what PPE is being provided to employees. With respect to the medical certificate of fitness, it must indicate recommendations relating to the employee's fitness to perform the inherent requirements of the job. If any restrictions or conditions are applied, it must be specified on this certificate, the period during which these restrictions or conditions will apply, accommodate the conditions and restrictions recommended, only permit the employee who has been medically certified for restricted duty to return to normal duty if the employee has been certified fit for those duties again. So normal duty will then, in this situation, mean returning to late work. So that is for that temporary removement of employees from late work. Documented system for medical surveillance include the analysis of the screening results over time to look for abnormal trends in health status, potential resulting from adverse effects of exposure to lead, and using the results to identify the need for targeted exposure prevention at the workplace. So this is also something that is common practice or good practice, but is now captured in the regulations, where we want historic results to be considered, health trends to be considered in the approach that we take around controlling exposure. The employer must provide, the employer must ensure that the employee provides written informed consent for the inclusion into medical screening, and also for medical surveillance, and the employer must ensure that the exit medical screening is carried out by occupational health practitioner if the employee is leaving their service. Also, as you can see, the medical screening and surveillance regulation is now really, I like to call it a monster. It's now really a very comprehensive, detailed, technical guidance for occupational health practitioners. Part of the reason for that is to make sure that we standardized across all medical service providers, to make sure that employees and employers at the end of the day get a similar service from these service providers. And also to ensure that there's a common understanding of what is expected of this medical fraternity when dealing with employees that are exposed to lead. But yeah, it's quite a comprehensive regulation as it is. But we are done with that now, so we're moving on to the next regulation dealing with respiratory zone. An employee must ensure that respiratory zone or temporary respiratory zone is declared for any workplace or part of a workplace where the concentration of lead in the air exceeds or is likely to exceed the OEL. You would have noticed from the definitions that we are not proposing a change in the OEL of the exposure, occupational exposure limits. It remains as it was. but that is being proposed by Technical Committee 7. During public comments, we might get some other views that we can consider. Then there's just some requirements around how do you demarcate and control a respiratory zone. The rest is very similar to what we have in the current regulation. Moving on to records, an employee or self-employed person must keep written or electronic records. The department does not expect everybody to have stacks and stacks of paper documents anymore. If their system allows for electronic records, that is fine as well. So records must be kept of the risk assessment, of the exposure monitoring, of medical screening and medical surveillance reports, training and refresher information and training records, maintenance of control measures, of the records of maintenance and control measures is important, especially where we look at local exhaust ventilation to control the airborne lead levels. It's important that that be done at a regular frequency and done according to the manufacturer's requirements. Records must also be kept of any reported occupational diseases. Keep records for a minimum of 40 years. Make the records available to the relevant health and safety representative or committee. Any person, provided that the records of personal medical records are subject to written informed consent of the employees. And also just to note that records that are being made available to the health and safety representatives or committee are not the individual medical records. They can have a summary of what is, what was found regarding exposure levels in general for the staff complement. They will not have access to individual personal medical records. That is not the intent at all. Control of exposure. An employee or self-employed person must prevent exposure to lead where this is not reasonably practicable. Control exposure, provided that the control of exposure shall be regarded as adequate if the results of exposure monitoring are at or below the occupational exposure limit for airborne lead and the relevant action level for blood lead. An employer must control employees' exposure in the workplace through basically the hierarchy of control. So the next part of this regulation just gives a step-by-step breakdown of the hierarchy of control. So obviously the first prize goes for elimination. If you can totally remove all lead compounds and products from the work environment, that's the best. Substitute lead where possible. And then we move on to engineering controls and administrative controls. And then finally, the last avenue is personal protective equipment. Once again, important here is to, when we actually get onto personal protective equipment, all the controls actually, is that we must consider all routes of exposure. So this is just some more information on the personal protective equipment that needs to be considered. The only thing that is maybe worth noting here when it comes to respiratory protective equipment, there is a requirement, although we are not requiring fit testing, we require the employee to make sure that the masks or respirators provided are adequately or fit adequately, and make sure that there is a proper face seal. So I'm just going to move over these quickly. I understand the recordings will be made available, and I'm happy to share the slides as well for people who want to maybe go through these slides that I'm skipping over in a little bit more detail. But as I said, I wanted to focus on the aspects that are more relating to the medical and the health side. the personal protective equipment and facilities is also a pretty comprehensive regulation. Also in the lead regulations, as in the past, there is the requirements for personal protective equipment that can be reused, like overalls and boots, to either remain on the premises and not be taken home, and then on the premises to provide adequate washing facilities, separate lockers, and also if the washing facilities for the laundry and the equipment is not on the premises, and a service provider is being used to wash those things, that they are also aware of the possibility of lead exposure and that they also comply with these regulations. Cleanliness of premises and plant. This is a section in the regulations that is unique to the lead regulations. We don't have this in, for instance, the regulations for hazardous chemical agents. And that is mainly because of the fact that we are concerned about absorption through the skin and ingestion as well with lead. So a clean and dust-free environment are of great importance when it comes to lead exposure. Maintenance, examination, and testing of control measures. Here we are looking at the engineering controls, especially ventilation systems. Employee or self-employed person must ensure that inspection, examination, and testing of engineering control measures are carried out at specific intervals. It's usually the manufacturer that will provide those intervals, and written instructions are established for the inspection and testing of these control measures. Where ventilation controls as a form of engineering control are provided, the employer must ensure that testing of ventilation systems is carried out at least once every 24 months by approved inspection authority. Here we have the hygienist involved in this matter, and they must record their findings in writing. Tests by approved inspection authorities must be repeated after any change to the control. So if there's an addition or a new outlet or a new filter being used, the test must be repeated. Written reports by approved inspection authority shall clearly indicate findings and specify recommendations for corrective actions to ensure exposure remains below the OEL for lead. Then moving on to prohibitions. No person shall use compressed air to blow away particles of lead from any surface or person, or require or permit any person to use compressed air to blow away particles of lead from any surface or person. Excuse me. Smoke. No person may smoke, eat, drink, or keep beverages or food in an area specifically designed, not specifically designed for it, or require or permit any person to smoke, eat, or drink, or keep food and beverages in such an area. So obviously, where lead work takes place, we do not want people to keep their food and their drink there, or be allowed to actually consume their food in those areas. Lead paint may not be used for painting the interior of buildings, used on furniture, scraping or rubbing down from surfaces through any dry process, removing by burning, or recycled into non-lead processes. As we said in the beginning, the new requirement is then also for lead to be classified, and then the labels must be developed according to that classification. And it talks about all the GHS required labeling elements, such as signal words, pictograms, precautionary statements, and such. Disposal, very much as in the past, obviously lead waste is considered to be hazardous waste, and here we share the responsibility with the Department of Fisheries, Forestry and the Environment, and we are referring to their legislation in this section. Obviously, when we get closer to promulgation of the final regulations, we will just make sure that these regulations are up to date and we are referring to the correct documents in that case. Yeah, there's a little bit of more information. Important here to note that anybody who is collecting or transporting the waste on behalf of the employer obviously also needs to have the proper training, information, personal protective equipment, medical screening where needed, and then also comply with these regulations. Offences and penalties, this very much didn't change. Yeah, if somebody's got the time to maybe just double check the specific regulations that actually have offences and penalties, they're more than welcome to do that. The fines mentioned here didn't change. That is very much dependent on what will happen with the new Occupational Health and Safety Bill. We expect that will then have a knock-on effect to all the offences and penalties in all our regulations. The repeal of the regulations, the late regulations published in February 2002 will be repealed by these regulations, but we will make provision for an interim period, a phase-in period of 18 months, or let me rather say 18 months are being proposed at this stage. Yeah, we'll see what happens in the public comment and what the advisory council of the minister actually allows for. So the idea is that these regulations, when the new regulations, when they get promulgated, will not, overnight become a requirement. It will be out in the public domain for a period of 18 months, allowing companies to transition to the new requirements. They can, during any time of that 18 months, then start implementing the new requirements and adhering to the new standards. But then after that 18 months, that is the final cutoff, then everybody would be expected to be on board with the new requirements. So that is just, as I say, to facilitate a transition period. And then these regulations shall be called the red regulations, and that XX will then be replaced by the appropriate year, maybe 2025, 2026. Still a long way to go. Annexure A, as we said initially when we looked at the definitions, Annexure A is the compulsory GHS classification for lead, and there are 3 CAS numbers they provided with the specific classification according to GHS. Respiratory category 1, it talks to all 3 the hazard classes, health, physical as well as environment, and the classes and categories are already given and, as I say, compulsory. And from this information, the labels and safety data sheets will be developed. Annexure B has got 2 tables. Table 1 talks about the frequency for blood lead level screening and the blood lead levels. So on the left side, we have a column there that gives the different types or categories of employees: your general employees, the vulnerable, reproductively able, and then pregnant or lactating women. And then we have the action level. We expect, red flags to go up and the medical practitioner as well as the employer to start taking note and start taking action. Then the suspension level, when we expect employees to be removed from late work. Then the level where they may return to late work, the medical screening levels, and then the frequency of biomonitoring, and that is provided for in months. And then some of them, the frequency is with regards to especially vulnerable employees, are left to the determination of the occupational medical practitioner as to when those needs to be done. Then table 2 is the frequency for total urinary lead levels. Once again, the first column talks about the different kinds of employees, and then the action level is not applicable for urinary lead. Then we have the suspension level, return to work, and then medical screening and surveillance, and then the frequency of biomonitoring. Once again, there are some sections where the frequency is left up to the occupational medicine practitioner to determine. So you'll see, although the current or the old regulations also have tables, it's a different approach. Those tables really talked about, that was the phase-in period, basically, where there were set targets for everybody to follow. Now this is more when an indication of the frequency when specific test needs to be repeated for employees. Now that's it on the regulations. But before I close and ask for questions, I'd just like to maybe give you an idea of how we got here and what's going to happen further. So these regulations, as I indicated initially, was developed by Technical Committee 7. Now Technical Committee 7, as well as ACOSH, which is the Advisory Council on Occupational Health and Safety to the Minister, are both tripartite structures, which means we have representatives in both of these meetings from organized business as well as organized labor. So that means when we actually table a proposal, both these parties, as well as our technical experts, needs to be happy and content with what we are actually proposing. So as you can imagine, sometimes it's pretty difficult to convince organized business to agree to projects or requirements that require them to spend money because they want to make a profit, and then organize labor, on the other hand, for them the health and the safety of the employees are of utmost important. But we've taken it to both those processes, and they have agreed to allow us to go out for this public comment phase, which we are in now. That this lasts for a period of 90 days, and that ends at the end of May. So Technical Committee 7 will look at all the comments that have been submitted in writing to us. We'll consider all of them, but considering all of them doesn't mean we will accept all of them, but every comment will be considered. From that, a new draft will be developed, and then that draft will then undergo the socio-economic impact assessment, where we will justify the regulations as a whole and see that we are not placing an overburden on industry when we actually promulgate. We will get the state law advisor's opinion on the regulations, which then they check for us, are we not in contradiction with any other legislation, especially the Constitution. It will undergo language editing, because I think there's only 2 people on the technical committee that actually speaks English as their first language. So that's sort of an important aspect for us. And then that new draft, after those 3 processes, will go back to the Advisory Council for the Minister. And if they are then in agreement, we will submit to the Minister again. And then we will have a final product that can get promulgated and is ready then for implementation in the South African industry. So just a request, we have developed a specific commenting format. I can provide that to Prof, and you can disseminate it if you'd like. And we're asking that you also send your written comments to the dedicated email address that we have created specifically for that. And please don't send it after the due date. We will not be able to consider late submissions. We also get audited on our processes. So thank you very much. I don't know if we have time or if there are any questions.
Yes, we do. Thank you so much, Elize, for that very comprehensive presentation. Yeah, the floor is open for questions. So please raise your hand and I will then give you an opportunity. I'm not seeing any questions at the moment. I have a question for you. With regards to the medical surveillance, you use occupational health practitioner and occupational medical practitioner in different aspects. Can you just clarify which aspects are in the realm of the occupational health practitioner and which are in the realm of the occupational medical practitioner? Thanks.
Right. Thank you, Prof. Yes, that as you probably know, that is something that is a hotly debated aspect through all our regulations. So, as I said, we had 3 occupational medical practitioners in the TC helping us and guiding us through this. So if I can, in short, try and explain what we foresee is that the occupational medical practitioner will take overall responsibility and accountability for the medical screening and surveillance for that system. But that leaves open for the occupational health practitioner, or traditionally what we would refer to as the nurses, then to actually conduct these tests. So, and then once again, back to the OMP to evaluate the results and make any diagnosis or give an outcome of those tests. So that is in short and in general, if I can explain it. So we really try to be very clear as to where we have specific duties that can only be conducted by the occupational medical practitioner. And I invite colleagues to please give us your input on that. We are open to look at your considerations. And if you have concerns about it, please raise that for us during this period of public comment.
For that clarification, Dr. Dave Knight, you can unmute and ask your question.
Thank you so much. It's really it's really great to see that they're reducing the blood levels at which certain thresholds are breached. But I'd suggest maybe those levels are still too high. If you just look at what's happening in Europe at the moment and the review that the European Chemical Agency has just completed and draft legislation in the EU to reduce workplace levels to less than 20, and even in some instances in Germany, for instance, to try and reduce levels to as close to background levels. So I'm still a little bit surprised that you can return to the workplace with a blood lead level of 30. I'd suggest that maybe that's too high. When we're seeing critical health effects starting to occur in men, for instance, at levels of around 17 or 18.
Maybe if I can just add to Dave Knight's question and also ask, why was the OEL not reduced? I see it's still 0.15 milligram. The ACGIH TLVs are at 0.05 milligrams per meter cube. Thanks. Elize, maybe you can respond to both. Thanks.
Sure. Let me start with the OEL and the comparison with the ACGIH TLVs. Colleagues would know that the ACGIH, they base their TLVs only on health considerations. So there's no other considerations when they actually make a proposal or when they make a TLV. In comparison to that, as all OELs or all other legislated and implemented occupational exposure levels have other considerations as well. And in the case of South Africa, it's very much socioeconomical impact. What can industry actually achieve and have levels that are not so burdensome that we actually kill off industry. So that is not the intent. So yeah, so that's with regards, although we look at the ACGIH, as we do for all other chemical agents, we need to have additional considerations. We can't just go for purely health-based effects. When it comes to the blood lead levels, yes, I expected that we will get some comments to saying that these levels are still too high. But I would like to point out that these levels are for occupational exposure only. So we are talking about adult workers in the work environment where we assume that they are of relatively good health and taking care of them and monitoring these levels. This is not community-based, and this is especially not blood lead levels that we consider or are proposing for children. That is an entirely different ballgame. We all know about the risk of lead and the impact that can have on even intelligence of kids. So that is not the mandate of the Department of Employment and Labour. So it's important for us, and we are in talks with the Department of Health to make sure that we are in agreement as to how we're going to approach this. We want to make sure that these levels for occupational exposure are not considered for community, for children specifically. The health levels of the levels that Department of Health are considering for community exposure must be considered. So it's for us, it's of great importance to make sure that we don't have occupational exposure being transferred to the home, that the fathers and mothers that are returning from home after working with lead, that they now take contaminated clothes or articles back home where they can expose children. So that is why we are also talking to the Department of Health as to how are we going to be dealing with notifications of elevated blood lead levels or lead poisoning to make sure that we prevent work exposure being taken to our communities. So, Dr. Davis, please, if you have a proposal to make with regards to reduction in blood lead levels, this is your opportunity to please provide us something in writing along those lines. I can just say that the two of the occupational medical practitioners on the TC really spent long hours and long nights considering these levels that they are proposing. But as I say, we can't just look at what is purely a health consideration. We have to, as TC7, also look at some other impacts so that industry will still be able to actually employ people. We know we are struggling with a exorbitantly high unemployment rate, so that is also something that weighs heavily in these considerations for us. I hope that clarifies to some extent, Prof.
Elize, I have one. I don't see any other questions. Perhaps I can ask then another question. I see in the new lead regulations there's no reference to ZPP levels that were in the previous lead regulations. Can you perhaps tell us, give us some background as most of you may know, ZPP, zinc protoporphyrin levels are also used to monitor for lead exposure, and they are also very sensitive with regard to picking up effects of lead at the subclinical level. Would you perhaps want to give us some background with regard to that? Perhaps it's an unfair question since the occupational medicine specialists that were on your panel are not here, but could you give us any background?
Yeah, what I can definitely tell you is that we did extensively discuss that, and that the doctors went and did a lot of research. And I'm going to lie to you if I say I remember exactly why they said we are moving away from it. I want to say that yeah, I'm going to lie if I try and recall exactly what the outcome of that is. I'm going to go back to them and just ask them to give me a short paragraph and answer that question for you. But it was definitely considered. I want to say that, you know, the technology, yeah, there was advances in test methods. That's why we moved away, and that there was difficulty in finding a standard to actually compare it to, but I'm speaking under correction when I say that I will get back to you with a firm answer after consulting with my OMPs.
Elize, that's a useful sort of at least some preliminary information. Okay, I don't see any other questions. We are beyond our time for this particular slot. I just want to remind folks that Elize mentioned that due date for comments is the 31st of May. And so I have circulated the template, but should you require that, please contact us and we will recirculate that. Then I would like to just thank Elize for her time and for her contributions, and all of you for attending this particular session, and I hope that it was beneficial to you. As indicated, we are recording this particular session, and so we will make this available also. We will make the link available to you should you wish to share this or review the input. Thank you so much, and I wish you all the best. Bye-bye for now.
Thank you. Bye-bye.
Bye.